for one of the Pezcoller meetings, seminars, which we organize since the year 2000. And we always try to have these interactive, informal seminars with the best pathologists in the field, and to have a really interactive seminar. I wish to thank for coming here to our city, Professor Gassain and Nora Katabi, who is actually not here in the room. He will arrive a little bit later, and Professor Giorgio Tallini. As you know, they are a great expert in thyroid and salivary gland tumors, and they will share with us their knowledge and their cases. And you are invited to interact and to ask. I will try also to stimulate the discussion. It's very important to have a very free discussion and to interact with the faculty. With such a great opportunity to have such a spectacular faculty here with us. And I will also thank the organizers who allowed us to put together the seminar. First of all, our local health trust, and the director of our health trust sent you all his greetings. He could not be here. And also the University of Trento, which you know just started a School of Medicine 4 years ago, and which gave us all the support. And finally, the Pezcoller Foundation, which is a foundation which has been founded by a surgeon, an old surgeon last century, who gave all his wealth to this foundation to promote research in oncology research. Dr. Veronica Folletto, who is manager of the foundation, will give you a short talk and show you a very brief video which summarizes this history of the foundation. Please, Dr. Folletto.
Good morning, everyone. I'm very pleased to be here as a scientific officer of the Pezcoller Foundation to welcome all of you to the 34th Pezcoller Seminar on Surgical Pathology of the Thyroid and Salivary Glands. Welcome also on behalf of President Galligioni, who unfortunately today was unable to attend. This seminar is part of a series of educational meetings we promote since 1995 to update knowledge on specific topics of oncology and share experience among participants and faculty members. I wish all of you 2 good days of work and interaction. And of course, I thank very much Professor Mattia Barbareschi for the spectacular organization. So before leaving the stage back to Professor Barbareschi, I would like to present you the Pezcoller Foundation and summarize its activities through a short video, which I kindly ask to start. Thank you very much and enjoy the seminar.
This is time of great discoveries in cancer science and significant impact on patients' care. Now more than ever, it is necessary to support cancer research, and that is the mission of the Pezcoller Foundation, established in 1980 in Trento, Italy, by Professor Alessio Pezcoller. The Pezcoller Foundation pursues its aims through awards, education, and support to young researchers. Through the awards, the Foundation rewards the excellence of cancer researchers who contributed to increase biological knowledge and improve treatments and chances of cure. The Pezcoller Foundation American Association for Cancer Research International Award recognizes extraordinary achievements in cancer research. It has been conferred so far to the best scientists in the world. Remarkably, 4 of them have been subsequently awarded with the Nobel Prize for the same reasons. Other awards are given in collaboration with the European Association for Cancer Research, the Translational Cancer Researcher Award to excellent young European researchers. And from 2020, the new Women in Cancer Research Award, which celebrates the achievements of women in this field. And the Rising Star Award to very promising early career scientists. Through the Pezcoller Symposia, a series of annual meetings since 1988, the Pezcoller Foundation promotes debates among renowned scientists, and the scientific growth and interaction with them of young researchers, also favored by numerous scientific lectures and seminars for early career scientists. Moreover, the Pezcoller Foundation supports several research grants and fellowships for young scientists at the international, national, and local level, providing researchers with more opportunities to achieve their results and share them with the cancer research community. Excellence in cancer research is the commitment of the Pezcoller Foundation, pursued at different levels, in collaboration with the main scientific societies, for the benefit of all of us. This is time of great discoveries in cancer science.
Okay, thanks. So I really profound in depth with the Pezcoller Foundation. Pezcoller Foundation supported me the first time I went to the States to spend a period at Mayo, and following the Pezcoller Foundation supported us in our activities in surgical pathology, which is a little bit, a little part of the activity of the foundation. So, having said our greetings to our sponsors, I would like to invite the moderators of the session, Professor Maria Pia Foschini and Francesco Marolla, who is substituting Professoressa Staibano, who could not attend the meeting. And okay, thanks very much. And Professor Tallini is still fighting with the slides, had hundreds of slides, so we will enjoy a lot of cases. So thank you very much and have a nice day.
Okay. So,
hello, good morning to everybody. Thank you very much to Professor Mattia Barbareschi for the organization, and it's a great pleasure to be here. And please, my colleague is Professor Francesco Marolla.
Thank you to Professor Barbareschi. I'm deputy of Professor Stefania Staibano. I bring her greetings to you. I leave to Professor Foschini.
Well, thank you. The presentation, I think that is can be very short because all our speakers are very well known, worldwide known expert in thyroid pathology. So it's my great pleasure to introduce you the first lecture by Professor Giovanni Tallini on papillary carcinoma and indolent follicular patterned tumors. Please.
okay. Thank you, Maria Pia, and it is a pleasure to be here, and I'm grateful to Mattia Barbareschi and to the Pezcoller Foundation for having me here. So I will introduce the topic of thyroid tumors with an overview of papillary carcinoma and of indolent follicular pattern tumors, and then most of the course will be conducted by my old friend and esteemed colleague, Dr. Hossein. So, so the topics that I will cover is an overview of the current, where's the point? Of the current classification and what we have learned from a revision of follicular pattern lesions, and so we'll mention We will mention NIFTP, tumors of uncertain malignant potential. Then we'll talk a little bit about the papillary carcinoma subtypes, and specifically, how they have been their classification has been reshuffled in the 5th edition of the WHO. We will talk about briefly about these 2 points: thyroid follicular nodular disease and follicular thyroidadenoma with papillary architecture. And then we will talk about how we microstage invasion in encapsulated carcinomas of the thyroid gland. So let's begin with the first topic. And so basically, this is what we do when we diagnose a thyroid tumor of follicular cells. We have 4 ingredients to deal with. One is the presence of papillae, another one is the presence of nuclei, the relative proportion of follicles, and whether there is a capsule or not. And according to how these 4 ingredients mix, we have our different tumor diagnoses. This is plus, this is minus. So if we have a lot of papillary nuclei, a lot of papillae, we have these type of tumors. And if we have a lot of follicles and a capsule, we have the other extreme. We do that subconsciously, but that's what we actually do in our practice. And till the 1980s, there was predominance of follicular carcinoma because up to about that time, thyroid tumors of follicular cells used to be classified based on growth patterns. So the tumors that were predominantly follicular used to be called follicular carcinomas, basically. The ones that predominantly made papillae used to be called papillary carcinomas. A little bit of a confusing situation, which changed when, after the 1980s, through the work of Dr. Rosai, basically, it became apparent that PTC nuclei were an important criterion for the diagnosis of papillary thyroid carcinoma, as originally pointed out by Lindsay in 1960. So there was an important concept. However, it led to the abuse of the importance of papillary carcinoma type nuclei in our routine practice. So, the PTC diagnosis became predominant over that of follicular carcinoma, and some famous pathologists were already talking about the demise of follicular carcinoma. Now we have learned that things are a little, more complicated, but the same ingredients still work. We have classic papillary carcinoma, in which we have well-developed papillae and well-developed papillary thyroid carcinoma-like nuclei. And then we have classic papillary carcinoma, in which, however, there is a predominance of follicles over papillae, but they are still, classic papillary carcinomas. Then we have papillary carcinomas. Okay, the pointer is dead. Yes, it's dead. Well, basically, where there are only follicles and no papillae, but papillary carcinoma nuclei are well developed, and this is the PTC. Now it's live again. What happened? Oh, okay, I know. Okay, so these are the PTC infiltrative, and these are the the tumors that are predominantly made of follicles and that, however, are encapsulated, and this is the encapsulated follicular variant papillary carcinoma. And then there are tumors that you see on your right. This thing keeps on not working with me. Okay, follicular adenoma and follicular carcinomas, in which the okay, this is better. Yes, better. Thank you. In which we have follicles, we have a capsule, there are no papillary carcinoma nuclei, and we call this follicular adenoma or follicular carcinoma according to whether there is invasion. So basically, encapsulated tumors are all benign unless we prove that there is invasion of the capsule or of the blood vessels, while all these other ones, including the infiltrated follicular variant papillary carcinoma, are characterized by invasive growth and they are malignant. Now, this scheme fits perfectly with what we have learned from the molecular classification of thyroid tumors. We have BRAF V600E-like tumors and RAS-like tumors. And please notice that the sort of the fault line splits the follicular variant papillary carcinoma into two groups, those that are infiltrative, invasive growth, and those that are encapsulated, which are malignant only if there is invasion. And then, if we have encapsulation, obviously we have to look at invasion, and so we further subdivide tumors in those that are invasive, and these are the encapsulated follicular variant papillary carcinoma with vascular capsular invasion. Those that do not have invasion, and we call them, as you now know, NIFTP, and those in which invasion is questionable, and then we use the term uncertain malignant potential. And since there are papillary carcinoma nuclei, we call these well-differentiated tumors of uncertain malignant potential. Now, the same thing, mirror situation, is with follicular adenoma, follicular carcinoma. If there is invasion, we call the tumors follicular carcinoma. If there is no invasion, follicular adenoma. And if there is questionable invasion, we use the term uncertain malignant potential. And we call these tumors follicular tumors of uncertain malignant potential because no papillary carcinoma type nuclei are there. Now, this sort of view has been embraced by the current WHO classification. This is the previous one, in which all these tumors were lumped together, and here they have been spelled out into low-risk neoplasms and NIFTP, and tumors of uncertain malignant potential, and then invasive encapsulated follicular variant papillary carcinoma. Now we're going to go over these tumor types. This is the consensus paper on NIFTP from 2016. It was an important paper because it brought four things to the forefront. I mean, first, there was a consensus on a minimal criteria to define follicular variant papillary carcinomas. Then a pretty large number of cases were analyzed with a median follow-up of 13 years. And if there was no invasion, nothing happened to the patients. Then also morphology was correlated with molecular alterations, and the consensus terminology came up with this, personally, I believe, pretty ugly term, non-invasive follicular thyroid neoplasm with papillary-like nuclear features, which is also semantically wrong because there are no papillary nuclei. It should have been papillary carcinoma-like nuclear features. But, you know, the clinician and the patient representative on the panel didn't want the word carcinoma, so it came up, you know, the conclusion was papillary-like nuclear features, which I repeat do not exist because there are no papillary nuclei. You know, short after the, 2 years after the consensus paper, you know, this expert opinion paper came around, you know, because of concerns that tumors defined according to the criteria we saw previously for NIFTP did have, you know, I mean, I'm not going over the criteria. You're familiar with them. Basically, the tumor needs to be encapsulated, follicular growth pattern with less than 1% papilla, no pseudomoma bodies, no predominant solid tubercular insular growth pattern. There must be nuclear alterations of papillary carcinoma, no capsular vascular invasion, no tumor necrosis, no significant mitotic activity. So there were concerns that with this definition, you know, a number of tumors could actually go on and metastasize. So stricter criteria were advocated, in particular, no well-formed papillae. Now, the WHO has sort of taken these concerns into its book, its consensus partially. It's still, you know, less than 1% papillae, the definition of an NIFTP, so you can accept rare papillae in an NIFTP. And that is largely because of this work from Dr. Hossein in which essentially this is a very interesting paper. Basically, cases that were encapsulated were collected, all of them, regardless of the growth pattern or invasive features. So encapsulated tumors, either with papillary growth pattern or with follicular growth pattern, all lumped together with nuclear changes of papillary carcinoma, with or without invasion. And basically, what was found that the lowest number of papillae for tumors that metastasized to lymph node was 10%. So 1% seemed like a rather, safe margin. The smaller number of papillae for tumors that metastasized to lymph nodes was 5%. However, these were tumors that were encapsulated with invasion. Now, to some extent, it's not a big deal, because even if you consider NIFTP, which is essentially a benign tumor, papillary carcinoma, which is vastly follicular predominant with a few papillae, basically what happens is that you're still dealing with a tumor type that has excellent prognosis. As these has been known, well known since the 1980s. This is a work from Dr. Rosai, in which papillary carcinomas, which were totally encapsulated, had a very favorable prognosis. Another similar paper from a German group, and this is for Otto Evans at MD Anderson, who also noticed that these encapsulated papillary carcinomas carried a very good prognosis. And you see, if there is a total capsule, some patients did have lymph node metastasis, but distant metastases were absent and nothing happened to the patient. So the other important thing, sort of dealing with the concern raised in the consensus statement from 2018, was the role of molecular testing, which is certainly useful, particularly for doubtful cases, although it is clarified as a desirable criterion. However, if molecular typing is done and there is BRAF V600E mutation identified, that excludes the diagnosis of NIFTP. So basically, these are cases of this sort. You have a nodule encapsulated without invasion, circumscribed, and there are nuclear changes, very prominent. There is a internuclear inclusion here. So, if you're familiar with the proposed nuclear papillary carcinoma scoring system for nuclear alterations, these would be score 3, meaning prominent nuclear alterations. And in these tumors, if you look hard enough, if you take additional sections, you always end up finding some papillary structures. So how do you diagnose these tumors? You do not use the term NIFTP because there are papillae, and you call this encapsulated, well-circumscribed papillary carcinoma classic with follicular predominant growth pattern, and these tumors are BRAF V600E-like tumors, like just classic papillary carcinoma. So which means that by and large, NIFTP is still a histopathologic diagnosis. However, if available, as now it is in many medical centers, if you do typing, that's very useful. And, there are BRAF V600E antibodies that you can use as a surrogate for the mutation by immunohistochemistry, and these are less widely used in Italy, and they're a little more tricky to set up, but there are also NRAS mutation-specific antibodies which also cross-react with HRAS. The Q601R mutation is the most common NRAS mutation, which may be helpful in doubtful cases. Now, also the NIFTP terminology following the WHO can be applied to both oncocytic tumors and to tumors that have oncocytic features, and this is an oncocytic NIFTP, and this is a sort of micro NIFTP, a little focus of papillary carcinoma without invasion and with the nuclear alterations and follicular growth pattern. But if there is one thing that you always need to keep in mind is that when we talk about papillary carcinoma with follicular growth pattern, there are two completely different scenarios. There is the encapsulated follicular variant papillary carcinoma with vascular capsular invasion, which is a RAS-like tumor. This is the invasion, and these are the papillary carcinoma nuclear alterations. And then there is the infiltrative follicular variant papillary carcinoma, which is not encapsulated. It is invasive, infiltrative, and it is a BRAF V600E-like tumor. So these two tumor types are completely different in spite of the common follicular growth pattern and should not be confused in our pathology reports. Now let's move on to a rather controversial topic, tumors of uncertain malignant potential. Now, these are tumors in which, regardless of nuclear alterations, there are features of concern for malignancy, which is questionable invasion of blood vessels or of the tumor capsule. And which type of concern we have in our pathology report must be specified. And according to whether nuclear alterations of papillary carcinoma are present or absent, we call them follicular tumor or well-differentiated tumor of uncertain malignant potential. But this is kind of a detail. The important thing is that the concern about malignancy is not about nuclear features, but about alterations. All these are obviously follicular growth pattern tumors. Now, let me say up front that tumors of uncertain malignant potential is a term that should not be used when the uncertainty about the malignant potential is created by the surgeon and not intrinsic to the tumor. Sometimes we observe resections of follicular parathyroid nodules which have been essentially morcellated by the surgeon. Sometimes it does happen. So when there are iatrogenic laceration artifacts, the tumor is not of uncertain malignant potential, but should be called follicular tumor, well-differentiated tumor, not otherwise specified, and explaining that extensive discontinuation of tumor to neoplastic interface precludes adequate assessment of invasion. So tumors of uncertain malignant potentials are those tumors which are intrinsically, difficult to diagnose because they have questionable invasive features. And, obviously, when we have to make a diagnosis of malignancy, the burden of proof is on us. Every thyroid nodule is innocent unless proven otherwise. So, we have to be very judicious, very, strict with the diagnosis of malignancy because, we do know that a malignant diagnosis, a cancer diagnosis, has an important impact on the patient, on the treating clinicians, etc. So burden of proof is on us, which means that we have to sample our thyroid nodules very, very carefully. Ideally, if the thyroid nodule is like an orange, one should cut sections perpendicular to the capsule, which is, however, very difficult to do. What we do at our medical center, we sort of seriously slice the nodule and then we cut perpendicular sections at the apex. It's a little bit like we do with the apex of a prostate resection. Other people have suggested something a little weird, to peel off the tumor to capsule interface and then to submit these in the cassettes may be helpful to save space when including the specimen. And other people, this is very clever, thinking about food analogy, there is the mango recipe to sample thyroid nodules, and this is very effective, but only in cases where the thyroid dissection comes in the pathology laboratory fresh, which is hardly the case in Italy. But basically you cut the thyroid nodule in half, and then you cut sort of sections, you slice it like that, just like you would do with a mango, and then during the fixation process, actually, the whole thing flattens, and this looks like a very appealing and efficient system to process carefully, accurately process thyroid nodules in which you have to carefully examine the tumor to non-neoplastic parenchyma interface, and this recipe is from Dr. Tsibrowski from the University of Graz in Austria. Now, whatever you do, going back to our orange, you know, please don't do this, and I've seen that done. You know, you have a relatively small nodule, it's cut in half, it is squeezed in the cassette, and then obviously you have submitted the entire nodule, but you don't see anything, you just see one of the margins of the nodule. And once you have embedded and processed your specimen, obviously you need to carefully examine the tumor to neoplastic interface, and this is a case we had in which, you know, this is the original section, and it would have qualified as a follicular tumor or uncertain malignant potential for doubtful capsular invasion. But then, as you ask serial sections, you see that the actual nodules essentially travels outside of the capsule, and then, you know, this becomes a follicular carcinoma with capsular invasion. So it is important not only to embed the sample, but also to, you know, ask for sections and whatever you can to rule in or out invasion. And going back to the importance of carefully sampling our nodules, you know, this is another thing that I've seen done. This is a section of an encapsulated nodule with this funny thing looking like there. And then, you know, 10 blocks down the way, I saw this other thing. And basically what had happened is that, you know, this is the nodule with invasion, clear cut capsular invasion, but the pathologist who submitted the sections didn't look at the growth carefully. So he put randomly one section with invasion in one cassette, and then, you know, the other section, you know, 10 blocks down, instead of having sampled, you know, the diagnostic area, which should have been sampled like that. And so this means that, you know, when you sample a thyroid nodule, you have to be careful at the growth level, because many times invasion is actually apparent, even, you know, here in this high-resolution ultrasound image. And when you see these, you know, just think and put, you know, your sections appropriately, so that then you have the diagnostic area right available on your slides, and you don't have to suffer with recuts and other things. Now, another important issue is vascular invasion. I mean, how do you make that diagnosis? I mean, basically, you know, this is what I tell our pathology residents. You know, first of all, you see a space, and you have to make sure that the space is not a crack, but it is lined by endothelium. So you have to make sure that you're dealing with a vessel. Then you have to find cells inside the vessels, and you have to make sure that the cells inside the vessel look like the cells inside the nodule, inside the tumor. And then third thing, you need to make sure that these cells inside the vessel have been actually living there. They've been residing inside the vessel. That means either fibrin or an endothelial lining of the cells. And certainly these things don't count as vascular invasion. They're simply artifacts made by energetic surgeons who sort of squeeze detached bits of follicular cells inside the vessel, or during the process of taking sections in the growth room. Now, you know, we know that, you know, mushrooming through the capsule of a tumor means capsular invasion, but we also need to be careful, because some of these mushrooms, which look like capsular invasion, at higher magnification are indeed examples of vascular invasion. And this is important because, as you know, encapsulated follicular pattern tumors that have vascular invasion have more guarded prognosis from those that only have capsular invasion, that before they're called minimal invasive carcinomas. And so that's an oncocytic carcinoma with vascular, not with capsular invasion. Now, moving on with the concept of tumors of uncertain malignant potential, we have to make the diagnosis after there is thorough sampling and careful examination. And, questionable capsular invasion sometimes happens, particularly when the capsule is thick. I mean, how would you call a tumor like that, where there are protrusions which are very deep into the capsule but not outside it? Or sometimes you do see actually slamination this lamination of the capsule. There is the tumor, there is a capsule, then tumor cells, and then another capsule like that. And you see tumor, capsule, tumor, and then the outside. And, you know, sometimes this can be difficult to make sure whether it is invasive or not. And then there is the more pressing issue of questionable vascular invasion. And this is of particular concern as there might be, you know, an intermingling of tumor cells and blood vessels at the periphery of the tumor. And, you know, ideally one should have a polypoid protrusion lined by three sides by endothelial cells. When you have this sort of incomplete protrusions, is this vascular invasion or not? Another issue that another issue that I find difficult to deal with, if you have an encapsulated or circumscribed tumor with a very thin capsule, and then you have clear-cut vascular invasion, but on the facing the inner portion of the nodule. And the capsule is very thin, so it is very difficult to tell whether you're dealing with invasion of something that is at the capsule or, you know, facing the inside, which would not qualify as vascular invasion. Now, whatever we make out of these conditions, you know, the papers that have looked at these type of tumors has shown that there are no nodal or distant metastases or tumor-related deaths. And it is important that, you know, we should be clear that a tumor of uncertain malignant potential is not a tumor which is malignant, but with the malignancy of uncertain potential. It is a tumor where we are not sure whether there is a malignant potential. So it is not a malignant tumor of uncertain prognosis, basically. And sometimes, you know, the semantics gets lost with both patients and treating clinicians. Now, there is this pretty impressive paper from Ken Kakudo, a famous thyroid pathologist in Japan, who essentially he had patients and he was humble enough to go and look review all his cases, about 3,000 of them, where essentially he made the wrong diagnosis. And because some of these benign nodules metastasized, and he found 2 out of 3,000 that would qualify for follicular tumor uncertain malignant potential, which means that basically the uncertainty is less than 1%, similar to that reported for NIFTP. I mean, obviously, tumors of uncertain malignant potential are not, it's a diagnosis which is used sometimes in Europe. It should be used with, you know, very sparingly. You know, I impose myself the limit of, excuse me, I have to do that, of not making diagnosis tumors of uncertain malignant more than 10 times per year. In the United States, as Ronnie will tell you, you know, where pathologies are macho, very macho, they're either benign or malignant, there is no gray zone. All right. Now we move on to the next topic, you know, papillary carcinoma subtypes, and, you know, in the new WHO classification, there is no microcarcinoma anymore. That's, you know, we say farewell to that tumor type. So the first important thing is that, you know, the invasive encapsulated follicular variant papillary carcinoma is not a papillary carcinoma subtype anymore. It is a, you know, distinct. It is taken out from the papillary carcinoma family because it is a RAS-like tumor, and as I showed before, you know, it fits more with the RAS-like tumors that are malignant only if they are invasive. And then we have all the other ones that we may want to call conventional papillary carcinomas, although, you know, in addition to classic papillary carcinomas, there are tumors that are not so conventional. There is the tall cell papillary carcinoma, there is the diffuse sclerosing, the columnar cell papillary carcinoma, and the hobnail papillary carcinoma, an aggressive, rare aggressive variant. Now, this is a review which is essentially, you know, an effective summary of the major changes in the 5th edition of the WHO, and you know, some things are worth noticing. Tall cell, greater than 30% tall cell, but you know, tumor cell height has to be at least 3 times the width. It used to be 2 to 3 times, meaning 2 times. I have to admit that we pathologists look rather silly, in front of our clinicians, 3 times, 2 to 3, 3 to whatever. We are a little confused. And in fact, the reproducibility of the tall cell variants in papillary carcinoma is all over the place. And, these are these tumors where cells are clearly tall. But please notice one thing. Some of them are also kind of plump, and they look, rather oncocytic. And this is an important observation because it has to do with the work that we recently published. Because basically, and there are immunohistochemical surrogate markers, tall cell papillary carcinoma has the same mitochondrial DNA alteration that you find in conventional oncocytic tumors. The difference is that on top of that, you have a BRAF V600D mutation or BRAF V600D light mutation. And what happens is that this immunohistochemistry for BRAF V600D, all tumor cells stain. And here is the surrogate marker, loss of NDU-FS4 means mitochondrial DNA alterations. And where there are tall cells, the mitochondrial alteration is present. This is the accumulation of mitochondria in tall cell papillary carcinoma. And so this explains why, there is this confusion between tall cell papillary carcinoma and oncocytic papillary carcinoma, and sometimes this can create diagnostic problem. Then we have hobnail papillary carcinoma, which is so defined when there is more than 30% hobnail. Now, these percentages do not come up out of the blue. I mean, they are based on the evidence that indicates that above that threshold, the clinical implications that define the biologic features of the tumor are actually met, right? So, it's not like God has told us that 30% is a magic number. There is evidence-based data to support that. These evidence-based data may change in the future, but that's what we've got now, and that's why the thresholds are like that now. Now, hobnail papillary carcinoma is a very rare tumor, actually. However, particularly in cystic thyroid nodules, you do have hobnailing of cells, and this should not make us call the tumor hobnail papillary carcinoma, because otherwise we may end up overcalling the tumor. What happens in real hobnail papillary carcinoma is that there is significant nuclear atypia in addition to the hobnailing. And usually, the Ki67 is elevated, and P53 may be staining the nucleus diffusely, and this is important to keep in mind. This is a very nice paper from Justine Berletta at the Brigham in Boston. So, do not overcall hobnail papillary carcinoma. And then another tumor type, solid trabecular, greater than 50% solid trabecular growth. And this is an important tumor because, historically, it has been the first tumor type to be associated with a molecular alteration. And this is because of the Chernobyl nuclear accident. This is a picture from April 26, 1986. Some of you were not even born, but we were, and we all remember there was a big trauma in Europe. There was heavy contamination. This is actually Belarus, because the wind was blowing towards Belarus when that happened. Then Chernobyl was very close to the border with Belarus, so that's where most of the heavy contamination occurred. And tumors developed in children after short latency in areas of greatest radioactive contamination, well, solid trabecular variant, which were associated with RET-PTC3, which we now call NCOA4 RET. And this is from the original paper that reported the association. Now, this brings up the issue of papillary carcinoma with tyrosine kinase gene fusions, and actually the most common type of fusion-associated papillary carcinoma is classic papillary carcinoma, but there is a large variety of these tumors that can have rearrangement. This is an example of a diffuse sclerosing papillary carcinoma. There is no tumor nodule with rearrangement. And there are some histologic features that suggest that this tumor might be indeed a tumor carrying a rearrangement. First of all is the famous solid trabecular growth pattern. Then many of these tumors are actually papillary. Actually, they're very papillary. They have high density of papillae. And papillae are highly convoluted, and sometimes they're even glomeruloid. Then another histologic features is aggressive invasion with both blood vessel invasion and lymphatic invasion. And also low power, the growth pattern is typical. There is a multilobulated pattern or even a multinodular pattern. And then there is fibrosis. And if we find these features, you know, we may suggest that the tumor is a thyroid kinase fusion papillary carcinoma. Now, this is not a tumor type because these features can be found in tumors with other driver molecular alterations like BRAF V6 and D. But it is important. You know, these fusions involve, you know, the tyrosine kinase portion of several genes, RET in particular, that gets fused to other genes that drive the tyrosine kinase expression, and these rearrangements happen not only in papillary thyroid carcinoma, but in lung adenocarcinoma, although rarely, and also in hematolymphoid tumors. And other tyrosine kinase genes involved are ALK and TRAC1 and 3. Similar mechanism. Now, as a group, these tumors have common features. They happen particularly in young patients. They are aggressive at presentation. They can have distant metastases. They often have lymph node metastases because of the extensive lymphatic permeation. So, summarizing, young patients' radiation exposure, they are uncommon in non-radiation-associated patients. They're frequently high stage at diagnosis, and they may present with early metastases. The histology, multinodular lobulated growth, prominent intratumoral fibrosis, lymphovascular invasion evident histologically, common solid trabecular papillary patterns, and papilla highly dense and glomeruloid. And it is important because up to 10 to 15% of cases, including cases that are high-grade and aggressive, like poorly differentiated and undifferentiated carcinoma, may carry this diagnosis. And if you find features that suggest that's important for the management of the patient. Now, farewell to microcarcinoma. Okay, so this microcarcinoma business is quite important. I mean, it clearly doesn't make any sense to define a tumor type based on a stage criterion, which is size. But this was imposed on us pathologists when thyroid tumors used to be diagnosed based on palpation only. That's before ultrasound and before FNA screening. And then endocrinologists said that, you know, we can only palpate a tumor confidently up to 1 centimeter in diameter. And if it is less than 1 centimeter, we cannot palpate, and therefore we cannot diagnose thyroid cancer. And these patients used to present with, you know, lymph nodes to the neck. And so that's why we were forced to call these unpalpable tumors microcarcinomas. Now, obviously, they're not equal. There are some tumors that are very indolent. They sit there, we die with them rather than of them. And then there are simply low-stage papillary carcinomas which have not grown up enough. And actually, you know, it is not difficult to tell these apart. This is a work that we have done in Bologna. And actually, you know, most of these tumors, and it's always been known, they're very peripheral. The median distance of the tumor center from the surface of the capsule is 3.5 millimeters, regardless of the size of the thyroid gland, which is also interesting. And basically, you have 4 types of papillary microcarcinomas. Those that are greater than 5 millimeters and at the thyroid capsule, those that are large but away from the thyroid capsule, those that are small, less than 5 millimeters, but at the thyroid capsule, and those that are small and away from the thyroid capsule. These ones seem to be the most indolent. These ones seem to be the most worrisome. They often are BRAF V600D mutated, and they tend to have aggressive growth with sort of islands of tumor cells permeating the border of the tumor. And they are those that usually develop lymph node metastases. So they're not all, you know, they're all not the same. What's important, though, is that, you know, this business of abolishing the microcarcinoma 1 centimeter definition is important because, you know, the median size of a papillary carcinoma in Italy is 1.2 centimeters. So, which means that half of the tumors are equal or less than 1.2 centimeters. So you cannot just call microcarcinoma, you know, nearly half of all the thyroid cancers that you diagnose. And this has been so for a while. This is a very important consortium. I don't know if people from Trento, the endocrinologist, it is run by endocrinologists, but it collects in a prospective manner, you know, all thyroid tumors. And it is a very meritorious thing run by Sapienza University in Rome. And actually it's so accurate. Look, 2020, the the average size went up because of COVID, which delayed, you know, many papillary carcinoma surgeries, and so the sensitivity of the database was such that actually even the increase in size was picked up by the statistics. Now, so to try to tell apart the indolent small papillary carcinomas from the ones that are simply low stage, there was this attempt made from the Gotha of thyroid pathology, Juan Rosai, Virginia Livolsi, Sabrina Simoes, and William Williams, who came up with a proposal, you know, if the tumor is not, you know, a pediatric age, if the sum of all foci is small, if there are no aggressive features, if the tumor is found incidentally, if the entire thyroid is resected, no lymph node metastasis present or suspected, you can call the tumor not papillary carcinoma, but papillary microtumor. Perfect sense, make perfect sense. It's sort of validated with a simplified version by Professor Camazelle from Spain. But the WHO didn't feel that there was enough evidence for that. And it has to be said that if the tumor is indeed very small, you know, it can be very difficult to apply subtyping. So I call them, usually small tumors are all follicular predominant growth pattern because there is no room to make papillae. Papillae need, you know, a certain size to grow. And so I just call them papillary carcinoma, follicular predominant growth pattern 3 millimeters, and that's it. Two things, thyroid follicular nodular disease. Okay, basically these are cases that we have been probably still called multinodular goiter or multinodular hyperplasia. And it was felt that these terms are inappropriate because many lesions, thyroiditis, hyperplasias of different sorts, hyperthyroid conditions, can give us to enlarged multinodular thyroid glands. And often it is difficult to tell apart follicular adenoma, which is a neoplasm, from hyperplastic nodules, which in theory are supposed to be polyclonal. And several studies have shown that in multinodular goiter, some of the nodules are indeed clonal, so maybe they are true neoplasms. So basically, since we cannot tell hyperplasia from neoplasia, follicular nodular disease, it was felt to be a better knock-middle term. But, you know, in our pathology reports, you know, we should make an attempt to tell these things apart. We cannot call this, you know, follicular adenoma or multiple adenomas in a thyroid gland, which is clearly a goiter. So which are the criteria that, you know, I teach my pathology residents and which are shared by everybody, I guess. And, you know, ideally multinodular hyperplasia is made of many nodules. There is no capsule or the capsule is poorly defined and the histology is heterogeneous. There are big follicles, small follicles, etc. While neoplasm, which is encapsulated, well differentiated, is single. It has a well-defined capsule, often clearly evident, and it has a homogeneous clonal appearance. Now, I think if at least two of these criteria are met, you know, then you can call the tumor, okay, an encapsulated, well-differentiated neoplasm, follicular adenoma, NIFTP, whatever. I think that's useful. Follicular thyroid adenoma with papillary architecture. It is, according to the WHO, a benign, non-invasive encapsulated follicular surgery neoplasm with distinctive papillary architecture without the nuclear features of papillary carcinoma. Basically, these tumors have always existed. You know, I have to admit I'm personally a little critical of this name changing that we do with each WHO classification, which confuses clinicians. And, you know, you get a feeling that some of us want to become famous just because they're changing names, which I don't think it is really an ideal thing. But, you know, these tumors used to be called follicular adenoma with papillary hyperplasia. Again, hyperplasia is not a term that is in favor now. And so, you know, the tumor that used to be a subtype of follicular adenoma is now given a distinctive dignity as follicular adenoma with papillary architecture. Same thing. Most of these tumors have mutations in the CMP signaling, particularly mutations in the TSH receptor or the underlying GNAS gene that encodes for small molecules that translate the signal from the receptor to the CMP pathway. And these can be associated with several genetic syndromes, as in the case of McCune-Albright and also DICER1. And we shall see that shortly. So what do these things look like? Well, you know, they look like hyperplastic nodules. They're rich in colloid. And then there are these papillary projections with nuclear changes that are not those of papillary carcinoma. There may be a occasional clearing, but not much. There are these follicles within the papillae, and the stroma is often edematous. Some of these tumors may have cystic changes, and some of them, but not by no means all of them, may be hyperfunctional. So corresponding to papillary, plumbar adenoma. And obviously they're problematic for us because of the papillary configuration. They can result in false positive cytologic diagnosis, as in this case that was called suspicious for papillary carcinoma because of the papillary configuration. Now, why am I talking about this apparent detail? Because both follicular nodular disease and thyroid adenoma with papillary architecture may be the first manifestation of genetic tumor predisposition syndromes. And it may be us, the first one, to point that out. So we need to be aware of this. And I'm going to illustrate two cases briefly. One, a 15-year-old man, a 15-year-old young, child, basically, or adolescent, with symptomatic multinodular goiter. First of all, multinodular goiter is rare, particularly in males, before the age of 40. So when you have a 15-year-old person with a multinodular goiter, something is already strange somewhere. And this is what it looked like. It sure grossly looked like, multinodular goiter. But then, histologically, you have several nodules, some very cellular, with this papillary and follicular architecture. Here, papillary, rich in colloid. And then, there are these nuclei. And typically, as you can see here, nuclei are sort of intermediate. They're round, they're not with irregular contour, but they have clearing. So some of these nodules, when single, have ended up in the literature being called actually papillary carcinoma, or, doubtful. And, this is something to keep in mind, because these cases really exist in the practice, and they're often underdiagnosed. Now, we suspected that, so we did molecular analysis from the tumor, and we found a pathogenic DICER1 mutation with 30 to 40% variant limb frequency. And so just a few words about DICER syndrome. It is a tumor syndrome which is autosomal dominant, due to mutations in this enzyme that process microRNA. And it is a very important processing enzyme. And if mutated, the microRNA get not properly processed, and there is a whole dysregulation, generalized dysregulation of gene expression. One would have expected, a huge cancer predisposition tendency, but in fact, that's not the case. Although, a huge variety of tumors have been associated with the syndrome, particularly in young patients, in children. There are highly aggressive tumors like pleuropulmonary blastoma, which is in fact the first tumor to be associated with thyroid cancer, with DICER1 syndrome. And then, in subsequent times, all sorts of different tumors have been associated, Sertoli-like tumor and multinodular goiter, multinodular enlargement, particularly in young patients, but not of pediatric age, is a very common manifestation with the histologic features that I showed you before. And so how does it work from the genetics? There are hotspot mutations in exon 24 and 25 of the gene, which is the ones that we found in this case. And these, if you find these can be a second hit of an underlying germline mutation, which is however spread throughout the length of the gene, which is what happened in this patient. This is the pedigree, the young patients with a somatic mutation it was tested for germline, and it did have different mutation, you know, in another, portion here of the gene. So germline and hotspot mutation. How do you find these tumors? They are common in pediatric patients. They're either follicular pattern or colloid-rich tumors with papillary architecture with these intermediate-like nuclei, mostly benign. Sorry. Okay. So it seems like I have a poor relationship with the pointer, but okay, they're mostly benign, but they can be malignant and even poorly differentiated. There are hotspot mutations which may represent a second hit in patients with germline DICER1 mutation. So I killed this one as well. Okay. And that's our case. And then another patient, this is an older woman, 50 years old, with low-standing multinodular goiter. Again, here, predominantly follicular patterned tumors, some with colloid, others very cellular. Again, the papillary architecture. And now, since we suspected that this might have been a genetic syndrome, we did p-TAD immunohistochemistry, and there is clear-cut loss. The endothelial cells are positive, but everything else is lost in the tumor cells. This inactivation is common in follicular pattern thyroid nodules and is often epigenetic. But when you find that, you should again suspect a possible germline mutation of p10, which means essentially Cowden syndrome. And to do immunohistochemistry for p10 is cheap and effective. So when you have these histologies in front of you, you know what's typical is essentially the entire thyroid gland is made of nodules. Usually when you have a regular goiter, you have these nodules, and then there's confluent alterations, but there is still some normal thyroid tissue somewhere. While here, everything is nodular. You know, there are big ones, but then there are also smaller ones. There is no normal tissue anywhere to be found, and that is a clue. So Cowden syndrome, as you know, is the main manifestation of P10 hematoma tumor syndrome. This is due to inactivation of P10, one way or the other, with germline inactivating mutations. Thyroid cancer is the main, one of the main criteria, and multinodular goiter is a secondary criteria, but the killers are not, you know, follicular thyroid carcinoma, but are breast cancer and endometrial carcinomas, and also renal cell cancer. And indeed, we send the patient to genetic testing, and we need to know at that time, but at age 35, patient underwent surgery for a ductal carcinoma, and then 10 years later, another breast cancer. She was diagnosed with Cowden syndrome, so she had breast cancer, now thyroid, adenomas, and we are sparing her probably the endometrial cancer, which she could still have. So bottom line, if we have a thyroid gland that looks like this, with multiple nodules, this is a nice review from Giovanni and Jose, multiple nodules with papillary architecture bilaterally at young age. You have to think about a hereditary condition, either Cowden syndrome, in which case you have to do immunohistochemistry for P10, or DICER1, there is no immunohistochemical surrogate. And you need to do sequencing for the tumor cells, of the tumor. Now, closing on the lecture, subtypes of invasion. This is important from the practical point of view. Now all encapsulated follicular pattern carcinomas, which means follicular carcinoma, encapsulated follicular variant papillary carcinoma, and also oncocytic carcinomas of follicular cells need to be subtype based, basically microstage based on invasion. And so we have to call them minimal invasive. There is only capsular invasion, capsulated angioinvasive, widely invasive. I have to say that personally I hate the term minimal invasive because it is misleading. I just call these tumors capsular invasion only, in parentheses, minimal invasive, encapsulated and invasive, and then widely invasive. What does this mean? And which are the criteria that we use to diagnose invasion? Here in Europe, these are the criteria that we use, illustrated nicely by John Chang in his chapter on Chris Fletcher pathology book. There are criteria for vascular invasion, for capsular invasion. I'm sure you're all familiar with these criteria, and they're very practical and nicely illustrated. In America, there is a little bit of controversy on which are the criteria, but maybe Ronnie can tell about that. Bottom line, so if you have an encapsulated tumor that is only capsular invasion, you use the term minimal invasive. If there is an encapsulated angioinvasive tumors, you have to count the vessels, not because that's part of the diagnostic process. The diagnosis is based on finding vascular invasion, right? But for risk stratification, you have to count the vessels. Up to 3 is limited angioinvasive. 4 vessels invaded or more is extensive angioinvasion. And so how do you do that? Well, it is a little tricky and maybe even counterintuitive. I mean, this is the capsule of a tumor, and these are foci of tumor within, is this one vessel completely filled by tumor? Well, actually, you have tumor in one section, cross-section of the vessel, another one, and another one. So these actually counts as 3 foci of blood vessel invasion, even if maybe the vessel is only one. But, it may seem strange, but it is the rule, and that's because the study that validated the prognostic role of blood vessel invasion followed this rule, which is also, useful because, how can you know whether it is one vessel with a serpentine, arrangement in a tumor capsule? So you just have to count what you see. And that is what we do here. There are 3 vessels, although it probably is a single, 3 cross sections of the vessel, although it may be just one vessel, but who knows? And so each cross-sectional focus of vascular invasion counts as 1, and this is important. Now, in your reports, it's not like you have to count foci of vascular invasion 2, 3, 7, whatever. You just, get a feeling, and then you say whether it is more or less than 4. And I just briefly mentioned molecular in this talk, but one thing I want to mention because it is important of all, we have markers that define the tumor type, BRAF V600D-like markers and RAS-like markers. These are markers for diagnosis. And then there are markers for prognosis. And if there is one marker that you have to keep in mind is TERT promoter mutation, because it is a very powerful prognostic indicator. There is unfortunately no surrogate marker for that because it is mutations in the promoter of TERT, but this is a very nice paper from Korea. They have looked at minimal invasive follicular thyroid carcinoma, encapsulated invasive follicular thyroid carcinoma, and widely invasive follicular thyroid carcinoma, and they have stratified them based on the diagnosis, regardless of whether there is presence or absence of TERT promoter. And this is the cancer-specific survival and the disease-free survival of patients. And you see that basically TERT promoter identification is better than histology at finding, poor prognosis, meaning better than finding vascular invasion. I'm at the end. Encapsulated angioinvasive carcinomas with extensive vascular invasion should not be confused with widely invasive carcinomas. These tumors are diagnosed based on their gross appearance. They have a multinodular growth that closely simulates, both grossly and sometimes even microscopically, multinodular goiter. These tumors used to be by far the most frequent type of thyroid cancer up to the 1960s, before screening with ultrasound and FNA, again, when tumors used to be made, thyroid tumors used to be diagnosed only based on palpation, right? Now they're rare, very rare, but they do exist. And if you don't know them, you can make, significant mistakes. You have to look at the tumors grossly, very carefully. These nodules have, neoplastic clonal appearance, and also histologically you find that. So please remember, widely invasive carcinomas are diagnosed essentially based on the gross appearance, not on the microscopic appearance. And paradoxically, in these tumor types, when you have to go and look for vascular invasion, it's even difficult to find that because, some of these nodules are, essentially tumor plaques within vessels that have overgrown and eaten up the endothelial line. So thank you for the attention. I hope I've not... God, so I have to focus on the... But I have to focus over there. So basically, this is... Sorry? See, that would be helpful. So basically, this is the case I showed you before, the real case with loss of P10. And I thought it interesting to sort of share the features at very low power. You see, we see these nodules that are, you know, looks at first sight looks like a banal case, right? There is this nodule which has got a capsule, sorry. Then there is the other one which has not got a capsule, but it is very cellular. Fantastic. So now I can focus here. That's much better. Thank you. So let's see. That is perfect. So cellular nodule, then there is another one, and then another one, and some of them have pseudo-invasive features. It's even difficult to understand whether they invade or not. But you know what I pointed out is that you know the entire thyroid gland is made of nodules. There is no normal tissue in the background. And when you see these features, you know, it's one of two things, or it might be, it's not always, obviously, but particularly if the patient is young, the first thing to do is P10 immunohistochemistry, because, you know, Cowden syndrome is not very common, but it is not that rare, actually. You know, basically what happens is you have a germline mutation, and then in the tumor, you have epigenetic inactivation of P10. And that's what happened in this case. And since we found the loss of P10, we, you know, then looked up at the clinical history of the patient, and we understood that the patient had clinical Cowden syndrome. We sent the patient to medical genetics, and she was evaluated and diagnosed with the syndrome. Actually, you know, we did better than medical genetics because, to be honest, they didn't like the case very much because they had actually screened the patient already because she developed breast cancer at 35. But they screened her for BRCA1. They didn't think of Cowden. So they sent the patient back. Now she has come back to them. So we have been even more powerful than medical genetics. So please, you know, again, they're not common, but they exist, and, you know, it's important for you to be able to recognize these tumors, and that is, yeah.
Actually, thank you for putting this case, because the Cowden syndrome I've seen much easier to think about. Some of your nodes have coloring. The one I've seen, super hypercellular, even don't find barely you can find coloring. So the other thing I want to ask you though, I have seen cases that Giovanni looked exactly like P10, just to bilateral tumors, like hundreds of nodules. Hypercellular, you barely see the coloring. And I've done P10 with the 2 clones, and it's negative, and these people sometimes in their 50s and 60s. But it's studied, I'm sure this must have a genetic, it's not very unusual for somebody in bilateral. You have cases like that, or did you try to study them? If you found something, you should really publish, because it's very frustrating, because I have to tell the outside, the clinician sent me the case, I don't see P10 amatomas. However, you have to look. That's what genus, I have no idea. So, comment on this.
No, it is true, actually. We had a case, I might even add it here. This patient was old, but when we looked at immunohistochemistry, we also looked at the clinical history. And then we understood, I mean, you don't need to be a genius to make the diagnosis of Cowden for that specific case. But what you say, it is very true. Sometimes in follicular pattern nodules, you do find a loss of P10, which is usually epigenetic. And, you know, we have the luxury of being able to do molecular you know, we are not a medical genetics laboratory, but we do molecular on somatic, meaning tumor samples. And when we find the loss, we also look at the mutation within the tumor. And if we find a mutation, that might be a germline mutation, right? Because if you have a germline mutation, it's also in the tumor, which is what we found in this case that I just showed you. We recently had one in a 54, 55-year-old woman, which was a cellular nodule, loss of P10. We did the testing for P10, and it was not lost. At that point, the story ends there, though, because there is a genetic loss of P10, which is actually, not infrequent in follicular pattern nodules. I'm not sure if I'm answering your question.
No, yeah. I mean, I'm just, Dr. Dilwyn Williams. For those of you who are young, this very still alive, very well-known British pathologist who described, who showed that carcinoma, medullary carcinoma from C cells and so forth. He described some familial oncocytic tumors and things like that. Have you ever seen these cases? And I mean, my question was, you have a case that looked like P10 by histology? You don't have P10, and you found, because of you do this genetic testing, you found no mutation, no, huh?
I'm on the lookout for similar cases.
I'll send them to you then, maybe if you want to genotype them.
Genotype, maybe. Memorial, you have super powerful tools. I think you need our help.
Do you have the monostaining for P10 to show?
It is on the, I have scanned it because I was looking through the archive to find it and I didn't find it, so I got very upset. But I have the scanned version, although if I have to put it up, we'll lose 5 minutes. So it is the picture I showed in the presentation. And this is the other one from the 15-year-old. Unfortunately, again, a 15-year-old with multinodular goiter. This looks more, less impressive than the other one. Here there is even normal thyroid tissue. But again, multiple nodules, some of them reaching colloid with these, with these, papillary projections. And here, the histologic signs are less well developed than in the Cowden case. But again, we have these papillae. And one thing that I want to show you, which is also useful and typical of these cases, is that when you go at, first of all, these nodules, and I think they have the Ki67, they're made of cells that proliferate. And I'm not, looking for anything. I'm just going to a random spot. Sorry. See if we can demonstrate that. Just like in the pictures I showed, although the nuclei are kind of intermediate. They have intermediate features between papillary and follicular carcinoma. Here, not visible. I have to go around. Because they're round without... is there an arrow? No. Yes, maybe. No? Doesn't matter. But they're round with no nuclear irregularities, but they have chromatin clearing. And you see that in some of the... Fantastic.
Sorry, Giovanni, you said it's all mitosis?
Not mitosis, but Ki67, is usually... is more than you would have expected, basically. Like here. For an hyperplastic... yeah, exactly. This is another typical...
Wait, this was it then?
no, this was the Dyson one.
Oh, yeah. Yeah, that I understand. So,
Now I'm thinking, so
I
we
don't
should
want
have guidelines for these things. So what,
I don't want
in
to
a young person, I should send for Dicer 1? Tell me, what should I do?
Yeah,
I'm a little bit confused.
the whole story of Dyson 1 is evolving. And I don't want to scare people. You know, it's not like you have you know, a multinodular goiter and you have to do, you know, to do P10 is no harm. I mean, it's an easy, but then you're at risk of putting yourself into trouble because, you know, then what do you do if you find the loss? But the bottom line is, you know, remember that multinodular goiter, particularly with the histologic features that we saw with Cowden, it is highly unusual in a 15-year-old boy or a 20-year-old boy. So
that's my point. You should have,
I think
you should develop like criteria.
You should do something.
Age-related criteria.
Yes, yes, but the whole story is evolving because, you know, another DICER1-associated tumor is thyroblastoma, although, interestingly enough, of the few cases of thyroblastoma that have been reported so far, they all have somatic DICER1 mutation, but in the few cases that have been tested for germline, they do not have germline mutation. So the whole thing is evolving, but the bottom line is that the vast majority of DICER1 mutated tumors of follicular cells are benign. They look like they're either follicular pattern, they're, or you know, colloid rich with papillary architecture.
Okay, so now let's say if this case, I would never have done, like you, I would never have looked for DICER1. What's the penalty? In what way I will harm this young girl if I miss DICER1 mutation? What is the scenario? What can happen?
Well, the pedigree is important because, you know, this is a germline thing. The boy was 15, and if he marries and has children, he, you know, may carry down the gene, and, you know, again, the genotype-phenotype correlation, the penetrance of these tumors is unclear, but, you know, maybe a one-year-old child of this couple will get pulmonary phleroblastoma or you know, embryonal rhabdomyosarcoma, which are serious tumors at young age. So that's why it's important to make the diagnosis. Again, the penetrance of the tumors is not well defined, but clearly if they happen at a young age.
I see.
Not.
Okay, I got it.
And the boy had a sister, 24-year-old sister, who also carried the germline mutation. So clearly there are problems. And another problem is you find the mutation and the patient is a child or an adolescent, you know, he's a minor, so you have to talk to the endocrinologist, who then has to talk with the patient, you know, the parents. It is a whole issue. On the you know, the alternative is to just close your eyes and just ignore it.
You said there's a penalty for this.
For the patient, so I still feel, I mean, we have many things that don't work in Bologna, Maria Pia, you know that, like I do. But at least one thing works, that usually we have good teams of pathologists, clinicians, and you know, we talk to each other, and so we are quite comfortable, you know, in you know, steps we take with the patients, etc. And so, you know, I consider myself privileged. But if you are just shooting diagnosis randomly in the darkness, you don't know who's going to read your report, then it can be problematic, and maybe it is better just to close your eyes, essentially. I don't know if I'm making myself clear, but so.
Is there any other question or comments from the audience? Do you have similar cases, and will you have none of you want to ask anything?
Maybe sure. I do have time.
Well,
right?
you have time. There's half an hour still.
Okay, so do we try our certain malignant potential thing? Although that may be...
Don't have the diagnosis before. You can show and then we can discuss on it.
I have to look for... Okay. Certain malignant... okay. taking the right one. Okay, we have an encapsulated nodule, obviously, which has been peeled off by the surgeon in part.
Can you tell us the age and the size of the lesion? A bit of clinical presentation?
Yes. It is a 42-year-old woman with 3 centimeter nodule. I mean, clinical histories for thyroid tumors are very simple. See if I'm not sure. So in any case, this gives you a feeling. So maybe I've not picked the right page. Right. Okay, yeah, that's what I wanted to show. Okay, so what do you do with this? I mean, you have an encapsulated tumor with a very thin capsule, and you have these sort of protrusions that are clearly within a vessel, and you know, they're at the edge. And there is more of that, let's see. So you ignore it, I guess. In America, what do you do?
If you're asking me, definitely this one I will ignore it because
The so-called vascular invasion, which is not, is below the capsule of the lesion. So
Okay.
absolutely nothing to worry about. I wouldn't like even mention, even if it was here, I would not even bring the issue of uncertain malignant potential. But the nuclei, believe it or not, for us, because we are so afraid of lawsuits, the nuclei are a little bit, believe it or not, irregular.
So you would call this what, NIFTP then?
1 second, let's see. Can you focus better?
NIFTP
please?
would be
No,
excessive.
Giovanni, sorry, I don't see. No, sorry. What actually is interesting here is you have a lot of bubble artifact. Did you see that? I will talk about it at the end of the day, what Dr. Rosa used to call pseudo inclusions. You show it, right? There's one, the bubble artifact here. Yeah, no, I wouldn't.
So you will ignore it?
No, yeah, sorry, I would ignore, yeah.
What about the audience? Do you agree to ignore or to consider it as vascular invasion? Yes. Who is in favor of vascular invasion? And the opposite, who is against vascular invasion, who would ignore? No, so most of them could ignore. Okay, and what about Giovanni? Can you comment on it, please?
Comment on what?
Do you agree with the ignoring this as vascular invasion, or
Well,
do you?
Again, it's. I personally called it uncertain malignant potential. The tumor was single, it was at the edge, and there are even more impressive cases. Let's see, what about this? So we are at the edge of a tumor. In a middle-aged woman, 5 centimeter nodule. Just looking for.
You're a little bit out.
If sort of this. Close intermixing of vessels, edge of the tumor. So
Your
there-
question here is?
Again, vascular invasion, doubtful, absent, ignore it, like here. And let's see. Here, they're all small vessels.
It's a little bit out of focus. It was not in focus, Giovanni. Thanks. Very difficult.
More or less in focus, right?
Yeah.
So, you know, for me...
Wait, look. Wait. Let's see what we think about, and then you throw.
Yes, again, let's do with raising hands. Who is in favor of vascular invasion? And who is against vascular invasion, who to ignore?
I would ignore.
Would ignore. Vast majority would ignore.
Very good. Let's see if I can find...
What did you call it?
I called it benign, this one. Because it didn't have capsule. Same one. It's a cute little stuff. Okay, let's move on to something else. Well, I did these with the loss of PT. Okay, let's look at this. So this is a 5-centimeter nodule from 41-year-old patient. Let's see if I'm...
Male or female? 41-year-old male, 5 centimeters.
Okay, so at low power it doesn't look like much, although seeing some slides here. And so we go along the capsule. So this is a thick sections like the one cut for the, not a whole mount. So we are at the edge of the tumor.
Who wants more high power? Very good.
So it is vascular invasion. This vascular invasion.
No, the other direction.
This way.
Not here. That lesion of blood? No, no. We have to wait for the lesion.
Here.
No, no, the lesion of blood, like the, yeah, here. Can you go on with power? Go towards yeah, yeah. Here.
Yeah, but don't tell the diagnosis, otherwise we'll get
No,
this.
I want to know. It's interesting. I don't know. I don't know.
Sure you do. So? Vascular invasion, yes, no, or no?
Who says yes? No raise hands. And who says no? No vascular invasion? Say
I would like
no.
to do a stain for vascular marker. For endothelial cell.
Exactly. So basically, this is an example of the papillary endothelial hyperplasia that you can find at the edges of large nodules, and you have to be aware of that. When I said to diagnose vascular invasion, you have to make sure that these things are vessels. They certainly are. There is an endothelium, but then you have to look at what the cells inside the vessel look like. These cells clearly don't look like the cells inside the tumor, right? So basically, if you do immunohistochemistry like we did, the problem is that I cannot, not the slides, but I don't know the plans. We did immunohistochemistry, and these were nicely positive for CD31. So this is papillary endothelial hyperplasia within the capsule, at the edge of the follicular pattern nodule.
Do you have some endothelial marker to show? Yes,
I
we are
brought-
persuaded, but I think that would be very
I
nice
brought
to see them.
I brought the slides, but they got mixed up here. Okay, found it. By the way, this is the case that I thought. This is, this one is an angioinvasive carcinoma, but because there is a clear-cut angioinvasion, or at least I think clear-cut angioinvasion in a different portion, a different portion of the tumor. Here. There. Sorry.
So that this, actually, I agree with you. But for the College of American Pathology,
Pathologist Giovanni, that is questionable, and we'll talk about it ad nauseum, so people not. But I completely agree with you with this vascular invasion. But if you, based on the
We know
paper
the story.
from Sylvia Esa, they consider this not vascular invasion. It's crazy, if you ask me. Yeah.
Anyways, so this is the immunostain we did, which is actually the double stain for TTF1 and CD31, which actually is quite nice. And it's nice because CD31 stains the endothelium, obviously, and for some reason that's the best I can do. Okay, so papillary hyperplasia, yes.
Can I ask why the College of American Pathology wouldn't consider it as vascular invasion?
It is a long story, but Ronnie knows. Yeah.
In the last, it's a big fight we had at the WHO, but Giovanni and I won.
No, I didn't. I'm not part of the College of American Pathologists.
No, but in the WHO they wanted to, but they were in the minority. Talk about it. I know the last talk, but yeah.
So this is the same case. Again, another example. It can be very tricky, to be honest. This is, it's not tumor, and the way to do it is you have to look at the crack. Is it a crack or is it lined by endothelium? There is endothelium, right? Then you have to ask, are these cells like the one inside the tumor? And they are not, sorry.
This is really difficult.
And you go back and let's see, I do have the immunohistochemistry hopefully here.
This one I would have tried.
Let's have to find. Got mixed up with the well, it was done and it's negative, but let me show you. I cannot find it. Okay, so that's the area, and this is the. Sorry, it is not in focus, but first I have to find the right spot, and then I put it. Put some dots. Should I put dots? I'm sorry. See, these are the protrusions, and you can see vessels within vessels, right? These are perithelial cells. The endothelial cells are staining, but there is no TTF1. And these are just all these excrescences inside the vessel. I don't know if this is on focus or not. Oh, okay. So actually better, right? So that's the. And actually, this is the case that I mentioned to you, that you mentioned, Ronnie, because this is the tumor, right? And because the patient was relatively young, now we are actively. Looking at these cases, we did P10. Histochemistry, and it was indeed lost. So this is one of the cases you the patient was relatively young, let me tell you the age.
fear in P10 done on every case.
Sorry. And then we are actively looking at these things. So it was colloid rich with macro follicular areas. The patient was relatively young, and we are actively looking for these cases now. And this is P10, which is lost, which is by itself not an uncommon finding, actually, the pattern tumors. And we did genotype the tumor and so immunohistochemistry is easy. I'll point out.
My point was, what is the threshold to do P10 staining? Because if you do it too frequently, you probably get a lot of epigenetic P10 losses, and you cannot afford to do
at the moment,
sequencing.
we are doing it on all follicular pattern colloid-rich lesions that look like, in the differential diagnosis with hyperplastic nodules. We are, trying to learn and see when we, it's more of a semi-research thing. And it is not common to find it, but when we find it, then we do genotype the tumor. And in terms of, recommendations for people who just do routine diagnosis, I would look for them only if the patient is young, with colloid-rich or follicular pattern nodules. Young meaning, I think, with multinodular goiters or with, follicular adenoma or follicular carcinoma less than 40 years of age.
40?
40, yes. I mean, to have a follicular carcinoma if you're younger than 40 years is not common.
Okay, thanks.
Some garden variety, I don't know if we have time, but garden variety, less common variety of papillary carcinomas, maybe. So, let's see. Okay. Let's look at these. Our appearance.
Age and sex and the clinical.
50-year-old woman with 1.2 centimeter thyroid nodule. You want to? You don't know what it is? Huh? You don't know what it is?
I know what it is.
I'm joking. So what do you guys think? I mean, so let's go low magnification, right? So the tumor is...
Cancer.
Exactly. Is it invasive or not? I guess even at low power you can tell that it's invasive, right? Right? It has this sort of, lobulated appearance. There is one lobule here, there is another one here, which is detached, meaning invasion, another one there, and then it's possibly what you call this angioinvasion. Vessel or not?
Yes, who favors in vessel and vascular invasion, yes? Okay,
good.
I think that we have
We're all in
100% agreement.
I will do recaps though, because it's not
But so we first look at the outside and it is invasive. So we know it is carcinoma. Then we look at the inside and we have to choose whether it is, you know, one of the papillary carcinoma types or tumors that are not papillary. You know, I think you all agree that here the nuclei are irregular, nuclear clearing, right? And this is a solid trabecular papillary carcinoma. And you know, I'm showing this case because solid trabecular is an unusual type of cancer, papillary carcinoma, and it is one that may be associated with tyrosine kinase gene fusion, as this case indeed was. Patient age was 15, so that means not particularly young, clearly, but you know, you can see these features, multilobulated growth, right? There's one lobe here, another one, you know, just lumps of tumors sitting in the parenchyma, and then the solid trabecular pattern. And you know, it's not like if you see these, you say, well, I mean, this is a thyroid kinase fusion carcinoma. Not at all. I mean, you can have these with BRAF V6 and the D-like mutation, but you should think about it. And obviously, in this case, it's not relevant. But you know, whether this was an aggressive carcinoma, then it would have been important. And this is.
But sorry, if you don't have the possibility to make and sequencing and so on, which are the features in addition to hematoxylin and eosin suggesting that it can be?
Right. I said during the talk, I mean, it is multilobulated or multinodular growth, fibrosis, and then solid trabecular pattern, and then angioinvasion, either within blood vessels, as in this case, or in lymphatic vessels. I mean, to find blood vessel invasion in papillary carcinoma is not that common. So that's just the hints that you know, a tumor may be of tyrosine kinase. There was discussion at the WHO whether these tumors should be given you know, dignity of a diagnostic subtype, but you know, we all felt that it wasn't fair, it wasn't right to do so, because you know, overall these findings can be found in tumors that have other molecular applications. And so
what really drives outcome is
yes. And this is the diagnosis is pretty obvious, right? This is papillary carcinoma. And why am I showing the case? Because this is another example of a range tumor. You see, there are follicles, but there are also these very dense, very papillary things coming together. And then, this time I think I put a dot, hopefully. There are these things that so glomeruloid papillae. They look like Schiller-Duval bodies, basically. I don't know if you're familiar with those, but there are papillae within follicles. And maybe too high of a power here. Thing. And again, this is, you know, looks like a Schiller-Duval body with lighting outside. And this is what has been pointed out. Peter Sado wrote about this. And his review is basically right. So that's nothing. Now, we talked about papillary carcinoma, and I mean, Ronnie will talk about this at length in his talks. But, you know, there are some papillary carcinomas that are papillary. No problem with that. But, you know, which have unusual features. These tumors are rare, but they do exist, and they need to be pointed out because they have extensive areas of necrosis and mitotic activity. And it is important, you know, in our report, to begin the report with high grade and then papillary carcinoma, et cetera, rather than to call it papillary carcinoma and then, you know, mention that it is mitotically active. I mean, this is what the, sorry, this is tumor necrosis. Another.
This is paradigm shift, because when I went, I was that is for our patients. Michael Stage, we have a lot of people in trouble. But grade, we never thought about grade carcinoma for decades. Grade is very important because once the tumors start to have this, it becomes really radioactive by time. And we talk about this with this is really, we have to change our way of viewing. Interesting, but unimportant. Yeah, we never something mitosis and thyroid, but actually.
And sometimes, you know, the other thing to notice is that, you know, this is tumor necrosis. I mean, what is it that you call tumor necrosis, right? Well, in thyroid nodules, you often find necrotic areas because the fine needle aspiration, particularly if you have oncocytic nodules that are very sensitive to hypoxia. So sometimes, since now there is a lot of emphasis on grading things in general, not only in thyroid, but certainly in thyroid tumors of follicular cells and also medullary carcinomas, you know, what is it tumor necrosis? How do you tell tumor necrosis apart from ischemic necrosis? Ischemic necrosis is like myocardial infarction. There are, you know, there is clean, hyaline-like ghosts of cells, or tumor cells, while tumor necrosis is dirty, like the necrosis you find in colon cancer with, you know, apoptotic bodies, you know, macrophages here, right? This is, you know, colon cancer type necrosis. That's what you want to see. The problem is that sometimes this type of necrosis can be very focal, and you have to really look for it, which means you have to carefully sample your tumors.
Well, is there any question from the audience? Any comment on?
Can I show you just one quick case?
Yes.
Yeah? This is for the residents. Are there residents? Many. So many residents. Now, you wish you were a resident. You do. Unfortunately, you are the director of a department. So. This is dirty. Excuse me. No clinical data.
The most important thing in life is how old you are.
I know. So any resident who wants to volunteer the diagnosis, or at least to discuss it with me?
They get it, we should invite them as well.
Bologna, yes. So Course director, can you please name a volunteer resident to discuss the case?
Sclerosing diffuse variant.
Excellent, excellent. You know, to some extent, it is an instant pattern recognition. So what you see is these dilated vessels, right? With, you know, clear-cut emboli or whatever, if they are lymphatic vessels, but, you know, lumps of papillary carcinoma cells that spread throughout the lymphatics. And there is usually a large number of Samoma bodies. And these tumors, they're typical, that's why Dr. Hussein was asking the age of the patient. They're typical of young patients. The clinical presentation is you know, aggressive. They're often lymph node and even distant metastasis. Also because the tumors in the classic diffuse sclerosing form, they're difficult to diagnose because there is no lump, there is no tumor. So ultrasound, preoperative ultrasound screening is problematic. There is no tumor, essentially. Most, I mean, although that is not always the case, I mean, there are instances in which, you know, there is a more or less dominant lump of tumor cells and then the spread in the lymphatics. But it's important for us to recognize these tumors. This is one of the patterns also associated with gene rearrangements.
How do you stage with the TNA this
very good question.
tumor?
Very good question. You're clearly a very clever resident. Now, in theory, it should be a microcarcinoma because there is no, I mean, now there is no microcarcinoma anymore, but I mean, it is less than PT. I think the correct thing would be to put PTX because, and then describe in your report what you actually see, that this is a diffuse sclerosing papillary carcinoma, therefore it cannot be staged. If you have to apply the rules, there is no recommendation. I checked it up in the AJCC 2017, and they don't tell you what to do. I mean, personally, I think PTX, meaning cannot evaluate primary tumor size, and then, you know, see diagnosis is what you ought to do. Because the other option would be to consider the entire gland, which would make, you know.
But anyway, because almost always there are lymph node metastases and a lot, the patient will get radioactive iodine, whatever.
So he puts the greatest dimension.
I use as a, I mean, I battle with this like Giovanni. I use the entire, usually it's either involving one lobe or both lobes, so I put the side of the whole lobe, and usually there are like 10, 12 lymph node metastases, which is beyond the amount required for radioactive iodine therapy, even in the United States. So at the end of the day, it doesn't matter very much. What is, I think, more important is to pick up the phone and talk to the surgeon if you're small hospital, because they may be very worried about this because of metastasis. And you remember, it's child usually or teenager. So it's very important to tell the surgeon, don't worry, all the studies should die of it. When they are young and you have to give radioactive iodine, but reassure the family they're not going to and I think that's probably the that it has a bad reputation like breast cancer.
Well, so thank you very much for sharing these very interesting cases. And now I think we can proceed to the coffee break and meet here again in half an hour.
Capitato un po' con questa roba anche per colpa mia. Spero che sia andato bene. successo. Sì, è fatto male, devo prendere... Sì.
Buongiorno, prof.
Uè, ciao.
Come stai?
Che piacere vederti. E che devi fare?
Bellissima presentazione.
Sì, capito? I vetri mi sono un po' incasinati. Se devo portare qualche caso un po' più difficile da scolare. In America dicono che fanno il pistoletto, poi in realtà se ne sparano delle cazzate. Prego?
Qualcuno tornerà fuori dietro, loro. Sì, non voglio disturbarti.
Sì, no, stai scherzando. Sì, che cazzo.
Well, Giovanni, can you send me the talk?
Sure.
Sorry, I had to tease you to make it fun, otherwise
No,
it's boring.
not at all. I should have. Salve.
Piacere conoscerla, io sono Silvia, vengo dalla Spagna, Silvia Gamba.
Ah, bravo.
Ho
Ma
appena
sei italiano o spagnolo?
Sono italo-boliviana.
Italo-boliviano, quindi molto piacere. Spero. Ho fatto un po' di casino con i vetri, potevo trovare qualche caso ancora più anziano e
Immagino.
malignant potential. Lavori più a Trento?
No, sono venuta a Trento la prima volta un anno fa per fare uno stage di 3 mesi e ho mantenuto il contatto e vengo
Quindi
sempre
sei venuta dalla Bolivia?
Ora sono venuta dalla Spagna.
Dalla Spagna, perché tu vivi in Spagna.
In Spagna
E lavori
e
dove
ho
in
lavorato,
Spagna?
ora sono a Logroño, ho fatto la specialità Bilbao. Bilbao Nord.
Sì, lo so.
E Logroño si trova a 2 ore da Bilbao.
Grazie per essere venuto.
Ho portato 2 casi.
Ah, bellissimo. Sì.
Visto che ho pensato, guarda, vado a trovare.
Certo, infatti quegli
top.
casi da portare sarebbero da incoraggiare il corso di questo tipo.
Poi non sapevo se c'era l'opportunità, se
certo.
insomma se è adeguato, perché ne avete già tanti.
No, ma so come si dice. No, in questi corsi è sempre utile che i partecipanti. Tu adesso hai finito la specialità?
Ho finito 3 mesi fa.
Ti hanno assunto?
Sì.
Dove? E sei sempre lì?
Sì.
Infatti.
Sì.
Bene, bravo.
Niente, non so se. Guarda, uno è di questi
NIFTP.
L'altro invece è una variante rara.
Senta, aspetta.
Ma non so se.
No, quello è un lavoro